The Nursing Process, Standard of Care in Psychiatric Mental Health Nursing, Chapter 7. The objectives of this chapter is to look at what type of different approaches you need to do when you're assessing your adolescent, your child, your older adult, to differentiate between using an interpreter and a translator when doing and completing an assessment, what to do when you're conducting a mini mental status exam, or a mental status exam, I should say. What a psychosocial assessment components are, or a brief cultural assessment or spiritual assessment, explaining 3 different principles a nurse must follow with plans of actions to reach an agreement upon an outcome criteria. And then looking at your nursing process, mental health problems, how to address those items. Demonstrate your basic nursing interventions according to the Nursing Association standards of practice. So we're going to be looking at these things. So when you're looking at page 109, it shows you that nursing assessment process. You're conducting that your assessment components are that mental status exam, your psychosocial assessment, the physical exam, your history taking, your interview, using your standardized rating scales, and verifying your data, getting your collateral information that you're gathering. Once you've done this, you get and develop your diagnosis, your nursing diagnosis. You identify the etiology of the problem. You construct that nursing diagnosis. You get your problem list. You prioritize. You set up your outcome identification. Identify and obtain, make it attainable cultural expectation outcomes. You document. You make sure it's measurable. You estimate the time and the expected outcome. You start planning and ensure and identify safe, pertinent, evidence-based actions. You strive to use interventions that are culturally relevant, compatible with the beliefs and the practices of the patient, not you, but of that patient and their family. You document, you plan, and you recognize terminology. You implement basic interventions. You coordinate those care. Coordinate care is one of your jobs. You health teach and promote. You do milieu therapy. We utilize pharmacology, biological, and integrative therapies. And then in advanced practice settings, though that's our advanced practice nurses, our ARNPs, they're prescribing medications, they're doing psychotherapy, and they're consulting. And then we all need to, and this is where nursing falls short in practice, we need to evaluate, and we do this by documenting the results. And if the outcomes are not being achieved at the desired level, we either need to gather more data, we need to reassess, and we need to revise our plan. So those are the things we need to be doing. So the terminology that is listed here are things you need to be able to define and describe. They are listed throughout your chapter, and we will be speaking towards these. So on page 110 in your book, box 7.1, we talked about QSIN and our safety in nursing. Okay, what is patient-centered care? What is quality improvement? What is safety? What is informatics? What is teamwork and collaboration? What is evidence-based practices? These are things that we need to be prepared to do. Evidence-based practices, what is that? This means we are using tools in our interventions that have actually been proven to be successful in outcomes of a patient, that they're successful, that it achieves the goals that we are setting our patients to be healthy, to regain success and health and well-being, and not waste things that do not succeed in success. Okay? So please make sure to review over those definitions and have a clear understanding. I know you've gone through these, so it's just a refresh and reminder. Okay? So let's talk about, and this starts on page 111. Make sure, I'm going to hit this very quickly. When you're assessing children, the best way to assess a child is watching them play. The best way a child learns is through play. Get a game out, get dolls out, get teddy bears out. When I need to have a child get a shot or a new procedure, I get the tools out, we play, we let them fiddle around with it and manipulate that item. When a child has been harmed, injured, and beaten or been in a domestic violence situation, I let them play with those toys and I watch how they treat them. It's amazing how a child who's having their little toys play at the dinner table and all of a sudden the child is smacking their doll around and telling them how bad they are and yelling and screaming and swearing at them. Well, where do you think that child's learned this? They've learned this through what's been done to them. And this is a good way of assessing and getting the information from that child. This is how you learn. This is how you assess a child. Child's not going to be able to tell you everything, but they can certainly show you a lot through play. Adolescents. What's the big deal about adolescents? What's their biggest hiccups of everything during assessment? They are afraid you're going to tell mom and dad. They are worried about you telling and breaching confidentiality and their privacy. Okay? So, when this is a big issue, when we are dealing with children or with adolescents, we need to be very conscious and very connected with them on recognizing that mom and dad are going to have a little bit of a hiccup when you're going to tell my parents. You need to be very upfront with them and say very clearly, if you're going to hurt yourself, you're going to hurt mom and dad, then, I have to tell everybody. I do not need to share details about things. However, if you're going to hurt people, you're going to hurt yourself, those are things we have to tell. This is a treatment team. We need to keep you protected. But the details we don't need to do. But I also want to remind everybody to know that part of what we do is we engage a treatment team. And part of the parents are part of the treatment team. And there's going to be family sessions. And family is going to be brought in, and there is going to be a time when that adolescent is going to tell their parents that I've been using drugs, that I have been having unprotected sex, and that I have been assessed for sexually transmitted disease. I've been tested for HIV. I am pregnant. I am whatever it is. We don't necessarily need to be the ones disclosing that information. That adolescent will be doing that themselves. But we're going to do this in the most therapeutic way to help reunite that family in a successful manner that is going to bring them together, not tear them further apart. So know that that's going to come out in the end, but it's not our job to disclose those things. That will be that adolescent's job to do. And we're going to help them succeed at doing this. Now, looking at, and with that in mind, Another way adolescents learn, so assessment and learning, I'm bringing both of these into play. Adolescents learn through role playing. Let's reverse the roles. You be the parent. Let me be you. I'm going to act like you. You be your mom and dad. Let's reverse those roles. Let's give them insight by changing the roles around. That does wonders to help that adolescent. So now let's move on to that older adult. So what's the big deal about that older adult? Before you start doing a whole lot of an assessment with an older adult so that you don't misinterpret and think maybe they've got dementia or they have early onset Alzheimer's or components, there is something that changes in an older adult. Who's got a clue what that is? All right. We have changes and may have some special needs that start to occur, especially when somebody starts hitting in their 60s, getting down into their 80s. Our 5 senses start to have some alterations. Taste, touch, sight, hearing, and smell. They start to diminish a little bit. And so we need to assess those things because of the fact they may be having a little bit of difficulties with hearing. And so when you start to notice that older adult turning their head to the side, leaning forward, doing that, what'd you say? Are they having difficulty hearing you? Or are they battling hearing voices and there's a competition going on? So you don't want to interpret that they're hard of hearing when it's actually voices that they're having to battle and they can't distinguish between your voice and the voice of the auditory hallucination they're having. So you need to clarify what is it they're experiencing. Sometimes we do see patients may have difficulties with their movement, their balance, so that we need to pay attention to those things. And also we do know that as a person ages, there is increase in anxiety and physical discomfort. So we need to pay attention to those things as they're moving. We do know that with the hearing piece, it does help a lot if we talk down in a deeper voice versus the higher pitch voice when we're speaking. It does help and assist with being able to hear. So what about the language barriers? We have already talked about this a little bit earlier in our culture chapter. Make sure that you are obtaining a certified interpreter, and also make sure that you're getting, if you have somebody who needs American Sign Language, or that you get somebody that actually can translate, that is certified to do so, and that they are certified in medical translation, so that we do not have any type of problem with their ability to give that information to the patient and be able to translate that information for us correctly. Family is not somebody that can do this. This does need to be a professional. And remember that when this is occurring, it is the facility's job to pay that person. It is not the patient's responsibility. It is the facility's responsibility to pay for those things. And that interpreter does need to be there for any time that there is an assessment, anytime there's education that is going on, a group, a therapy, assessment, an evaluation, any time that those kind of components are going on. They do not need to be at the site 24/7. It is only during those key moments of therapy, as well as, like I said, the assessments, educations, those pieces, okay? All right, so we've got those things down. I'm going to continue on. So Mr. R, a patient, is in his early stages of Alzheimer and he's not been doing well. He is aware of his family members, including his sister, who has moved in with him. I do not have to work, she says, so a neighbor downstairs, or I have to work, she says, so the neighbor downstairs checks on him during the day. There's a bell, so he knows if Edgar tries to leave by himself. Mr. R's sister has brought him to the clinic because she's worried about his recent loss and some progression in his disease. Okay, so this is why she's brought him in. So we're going to start with gathering some data. Okay, so we're going to go on page 111, and one of the things I'm going to talk about really quick is, especially with adolescents, a lot of times it's really nice to use what we call a heads assessment. Okay, and what a heads assessment is versus with an older adult, and we'll go into mental status exam here in just a second on 113, but I want to talk about a heads assessment real quick. We're going to start gathering data, and we're going to do a review of systems that we've done in the med surg. We need to know all the medical conditions. We need to get those vital signs on that patient, and we need to do a head-to-toe assessment, family history, medical conditions, what all these components, because you need to know what medical conditions a patient can have, that because several of them can mimic a can mimic a psychiatric condition. Those are on page 113, box 7.3. You can see with the in that box, depression, Alzheimer's. Depression can be mimicked by multiple sclerosis, by encephalitis, by Cushing syndrome, by pancreatitis, by sleep apnea, by thiamine deficiency, by cancer. Symptoms of anxiety disorders can be mimicked by a brain tumor, by a stroke, by neurosyphilis, by low calcium, by liver failure. Psychosis can be mimicked by a migraine headache, by an occipital tumor, by narcolepsy, by encephalitis, by hypothyroidism, by Addison's disease, by HIV, besides drug effects that can cause this. So if they show up to a psychiatric facility on your unit, but it is a medical condition that's caused, and I've seen this happen. I've had patients come and get admitted. I've had a doctor and a nurse in conflict where the doctor comes in the morning and the patient's up, walking, talking, and he was diagnosed in his teens with schizophrenia, but very functioning, stable, had a job, medication treating it, and all of a sudden in his early 50s, his hallucinations return. And he comes back into the hospital to try to get stabilized because in the afternoon and evening, his condition worsens severely where he's responding to the hallucinations, but it is affecting him with his ability to walk, talk, function, that he wanted to come into the hospital setting. And it has never been that severe, not even when he was in his teens. And the nurse would talk to the doctor every day because she worked in the evening shift and say, there's something really wrong, because at 12 noon, it's like this patient hits this brick wall and he has left-sided weakness. It's not even both sides. It's only on one side of his body that it's weak. It's like he's having a stroke. And the doctor's like, no, we did a full workup, had a full medical workup. They didn't find anything wrong, that it's not a stroke. There's nothing taking place. you know, it's just his schizophrenia. It's just symptomology of his psychosis. And we got talking, and because she's like, this is really, it's neurological. That is not in the sense of a neurotransmitter issue. This is more. And so we got debating, talked back and forth with the doctor, and we all decided we're going to do a Babinski reflex. And so we went down and we took the reflex hammer and went down to the bottom of his foot, and sure enough, we had a positive Babinski reflex. And we're not talking just the Babinski. He did a complete startle reflex from that. So the toes flared out, but his whole body flared with that response. This gentleman had either 5 or 7 brain tumors in his head. He lived for about 6 months before he passed away. But his schizophrenia didn't get worse. He had cancer of the brain. So again, it can mimic a psychiatric illness. So going back now to mental status exam. With adolescents, it's really good to use, and also the psychosocial assessment. I'm going to go to that one first, of using a HEADS assessment. A HEADS is a very quick technique, interviewing technique. H stands for home environment. What's your relationship with your parents and your siblings? E, education and employment. What's going on? Are you at school? How's your performance? What you're doing? Are you working? How's work going? What at your job? How's your performance at work? A, what's your activities? Are you participating in sports, after school activities? How's your friends' situation? What you doing with your friends? D, are you using any drugs, alcohol, tobacco use? And now vaping. S, what's your sexual activity? What's your orientation? What's your practice? Are you using success? Are you using contraceptives? Have you been treated for any STDs? S, suicide risk, symptoms, depression, or any other mental disorders. And then the other S is for safety. How safe does the patient feel at home, school? Do you wear safety belts when you're driving or getting in a car? Are you engaging in any dangerous or risky activities, such as, do you wear a helmet when you ride your bike, when you're skateboarding? What do you practice when you're surfing? Are you latched to your surfboard? Any of those kind of things that are safety components. That's the thing you would be doing with a child I'll even say a middle school or adolescent. Okay. So then, when we're talking about mental status exam, you're going to go to page 114. I'll just stay in the psychosocial. Sorry, guys, I'm jumping on you a little bit. Your psychosocial assessment, you're going to be looking on page 114, box 7.4. So what you're looking in there is just a little bit more detailed. We usually use this more with our adults. We look at previous hospitalizations, educational background, occupational background, social patterns, like describe your family, your friends, your sexual patterns, and that includes orientation, interests and abilities, your substance use and abuse, your coping abilities, and it's part of this also will include your spiritual assessment. And spiritual assessment's much broader than religion. This is your religious, this is what I practice and do. Spiritual is much more about your beliefs, your practices, versus I go to church, I'm a Roman Catholic. So tell me a little bit more about your spiritual beliefs. How do I want to do this? It may be more holistic in nature. Okay. I believe there's a higher power, that's a God. My spirit goes to heaven. It's just a bigger, broader components. Okay. My faith gets me through stressful times. Okay. And that also brings culture into it. All right. So, mental status exam. Okay, so a mental status exam. Now, this is what you're going to do, and this becomes part of your daily documentation of your SOAPy note. And we'll talk to this in the end. So I'm going to talk about this now, but this is the O in your SOAPy note. Appearance, grooming, dress, level of hygiene, pupil dilation or constriction, facial expression, height, weight, nutritional status, presence of body piercing, tattoos, scars. Because remember, if you are excessive on your piercings, your tattooing, it is a way of our society of expressing oneself, but when it is done in excessiveness, it also is a form of self-mutilation that we have tried to make as an acceptable way in society to, instead of cutting on yourself, you do it through tattooing and piercings. A relationship between appearance and age. Behaviors, excessive or reduced body movements. So are we manic, or do we have anergia? Particular body movements, scanning the environment, or odd or repetitive gestures, level. So are we looking like we're hallucinating and seeing things in the corner, or do we have some abnormal movements going on in tardive dyskinesia, or some kind of EPS movements or dyskinesia issues? Do we have a level of consciousness change? Is there balance and gait issues? Are we maintaining or keeping any eye contact? What's the speech? Is it rapid, normal? Is the volume loud or soft? Is there a disturbance in the speech? Problems articulating, slurring, stuttering, mumbling? What's the mood? What's the affect? Flat, bland, animated, angry, withdrawn, appropriate to contact? Is the mood sad, labile, congruent? Is the affect and mood congruent or incongruent? Are we acting all happy, but our facial expressions are sullen? And so we're crying and laughing at the same time. Disorder of thought. Are our thought processes organized or disorganized? Are we staying on topic or jumping from topic to topic? Are we thought blocking? Is our content delusional or obsessive? Are we having auditory or visual hallucinations? Our cognition, are we oriented to time, person, place, and situation? 4 levels. Are we conscious? Are we alert, confused, cloudy, stupor, or unconscious, or comatose? What's our memory? Our remote, recent, and immediate memory. What's our fund of knowledge? What's our judgment, our insight? What's our ideas of harming ourselves or others? Suicide or homicidal ideations, or current history or current thoughts, past or present. What's our present plan? What's our means to carry them out? What's our opportunity to do so? What's the lethality of that plan? You want to put that all into place. So we're going to look at that spirituality and the religious assessment. We're going to look at the cultural and social assessment. And so what are those questions that you want to be asking about that cultural component? Who's close to you? Who do you call in times of crisis? What do you value? What is important to you? Those are those questions. What's your primary language? Might not really be when you're asking about primary language, that's really what you're looking for interpreter. That's not really going to help you with culture, okay? You can be born in the United States and speak many languages, okay? That doesn't necessarily tell you about someone's culture, okay? So asking that is just helping you for those elements. You might want to ask about any special foods that somebody might want to have or eat, okay? But those are the kinds of things you want to be looking at. You want to validate your assessments, okay? So that means asking other people, going and checking the pharmacy or the outside healthcare provider about the information that you're gathering. You might want to talk to the family member to confirm information you're getting. Then the next thing that you're going to want to do is get and obtain rating scales, okay? These are actually evidence-based rating scales that are utilized. This is just a brief list that I pulled that are very common ones that we utilize. The Beck Depression Rating Scales, the Columbia Suicide Rating Scales, the Brief Patient Health Questionnaire, the Addiction Severity Rating Scales, the Recovery Attitude Treatment Evaluation. That is usually used for somebody with addiction issues that have been in residential treatment and they're getting ready to head on home. Mania rating scales for that bipolar patient, the eating disorder inventory. So these are just a load of rating scales that we provide with our patients. Okay. So as you begin the assessment process with Mr. R, stops you and says, I don't know why you need to do an assessment. I'm just here to get my medications adjusted or my medicines adjusted. How would you respond to Mr. S? What's the purpose of a psychiatric mental health nursing assessment? What would you say the purposes are? And so some of this we would say, but I want to talk about this as the whole piece. So you're there to, one, you're establishing a rapport with him. And you're going to let him know that you're there to obtain an understanding of what his current problem and his chief complaints are. You need to review his physical status and get a baseline set of vital signs. You need to assess those risk factors, right? Affecting his safety for him and then also for other people. You're performing that mental status exam, you're assessing his psychosocial status, and you need to identify mutual goals with him, and you've got to formulate up that plan. So yes, medicines can get adjusted and make sure the meds are going to do what he wants them to be able to do, so that we're all on the same page of what he wants those meds to work and do for him. So which term on the assessment is broader? That's right, A, spirituality. It's universal, okay? It's cognitive expert, it's behavioral, it's bigger, okay? It's much broader than just practices of worship and symbols, okay? You discover that part of Mr. R's lack of appetite has been due to a urinary tract infection, and he has been unable to articulate this. You ask his sister for more information about his home environment, his ADLs, and his medication. What type of information source is his sister? Is it primary, secondary, private, or informed? Yes, it is secondary information, or as I call it also, collateral information. Okay, so now we're getting into explaining the 3 principles the nurse follows when planning actions and agreeing the stuff. So what are our components? So a nursing diagnosis, we need that, and you can always go to page 64 in your textbook. It has the resources about the treatment plan back there. But primarily what we're looking at here is we're going to do the problem is identifying what the unmet need is, the etiology, the probable cause, and the supporting data, the signs and symptoms. So when I say supporting data, that is your assessment data. That is what you're putting there and that you're dealing with. So those are those 3 key areas we're looking at. So our outcome criteria, when we're looking at this, our outcome identification is reflecting the max level that the patient can realistically achieve. What can we get this patient back to level of function? The interventions need to indicate the patient's status. What does the patient want to achieve? What do we see the patient is capable of achieving? Then we want to, of course, plan. The principles to consider when planning care are safe, compatible, and appropriate, realistic and individualized, and of course, evidence-based. So we're combining a combination of our clinical skills, the use of relevant research in the delivery of effective patient-centered care. That is what evidence-based is in our interventions. So keep that in mind. And it's always patient-centered in our planning of our nursing care. So our basic interventions again, coordinating care, health teaching and promotion, and milieu therapy. And reinforcing again, milieu therapy is that we are looking at creating a safe, secure environment, including people, setting, structural, and emotional climate that affects positive change. So you can take an event that's happening and use it as a rich and learning opportunity. It must have a routine that's predictable and trusted. This includes orientating that patient to all to everything and where it is on the unit, the rules, their rights, their responsibilities, in always the most least restrictive environment possible. And then, of course, we always have the pharmacology, the meds we give, the biological, and all of the integrative therapies, activity therapy, group therapy, educational therapy, health promotion therapies, all those things that we do all day long, okay? Community therapies, etc. Then we have the advanced therapies that go on. That's that group therapy, that's psychotherapy, consultations, that's the ARMPs, and the prescriptive therapies that go on. So then we've got to evaluate. So with our evaluation, it's systematic, ongoing, criteria-based. So I'm going to talk about that a little bit more detailed here in just a second. So we're going to evaluate every time you do your progress notes on your shift and you're talking and documenting your patient, you're documenting to your treatment plan. You are evaluating how your patient's doing, where their status is to their problem that brought them into the facility. And are they hitting their goals, meeting their goals? If the goals are being met, you need to document that the goal's been met. Then do we write a new goal and continue on? and close out the old one, and do they get discharged then, or is the goal still ongoing? And always check the criteria to see if the criteria is being met, or do we need to revise? We keep assessing, reassessing. It's always happening. So our SOAPy note. Now this is on with our documentation page, but I'm going to switch you over to page, let's see, 120. You guys always talk about S-bar in Med-Surg. In psych, we use a lot of different charting, and it usually is an S-bar. We usually use something like SOAPy or BURP, so that we are putting in a bit more information of what the patient is saying, okay? So S is standing for subjective information. So we're quoting a lot of about what the patient's talking and saying. So this would be statements like the patient came in for suicidality, and the problem is patient at risk for self-harm. And they're saying, I want to die. My life isn't worth living. I hate my family. Or I learned today that I don't really want to die. I just have a lot of problems that are just very overwhelming, and there's some things I can do to make my life better. So we're quoting what the patient is that's focused to the problem, okay? Or maybe the patient's psychotic and they're telling me that there's a man standing over in the corner over there and they won't shut up. Whatever the quote is. So we're documenting what the patient is saying, okay? Throughout the day, just putting different clips of what they're talking about and saying. All right. The O is the objective. This is where your mental status exam is coming into play, along with your labs. It's all things observable and measurable. Okay. Affect, mood, behavior, hygiene, activities, their I&O, their speech, their volume, their pitch, their orientation level. All of that goes in there. So your S and O in the subjective and objective is going to tell us everything so that I can come down to my evaluation at the end and say their goals were or were not met during my shift. Okay, that's simple because my S&O is going to tell me everything about their day there. And so my A then is coming down and stating what my nursing diagnosis is. It should be the same pretty much of what my care plan is about. Okay, patient at risk for self-harm. Okay, but I would say patient continues to be at risk for self-harm, but say my patient's improving. So I may actually change my nursing diagnosis to ineffective coping mechanism or ineffective coping skills. So I may be changing my care plan, so maybe they're not at risk for self-harm anymore, and we're moving on to the ineffective coping skills at this point. Okay, so my plan. Now, when we talk about plan, we're talking about what are the future interventions for the next shift or the next day. They could be the same that's already in the care plan, or now we're moving more focusing in on the ineffective coping skills for the next shift versus the ones that are currently in the chart on at risk for self-harm. Then we're evaluating those goals that are there. Goals met, and I'm going to go to my care plan and put the date that the goal was achieved, and I'm starting my new care plan for the ineffective coping mechanisms. So documentation. It's crucial. You got to, like I just talked about, evaluate those outcomes. Include non-adherence. I know I talked about this a little bit in class on Thursday, but I want to make sure you get this. We use the word non-adherence versus non-compliant. Non-adherence means that there may be a barrier to not wanting to do what is part of the treatment. So we're going to find out, we're going to talk with the patient to find out why they're not adhering to the treatment. There may be, I can't afford it. The medicine's making me too sick. We need to find out what the barrier is and help the patient get beyond that barrier and help them so we can get them well. The medical record, remember, this is a legal document. We do not put our own personal judgments in there. This is a factual document. We put down what we see, hear, smell, taste, etc. into this document. The facts. So we have to assess, document, do not leave anything out. When you get called for a deposition, when you go to court, it could be 5, 10 years later, especially in the land of psych. You'll get called on an abuse case, a death, a suicide. Whatever you wrote in that chart is all that you have. And you may not remember or have a full recall, and if you didn't document it, it really didn't happen. And you will look silly. And you can be made to look silly. So you do need to be very careful. And the prime example that I did once was the fact that I said patient had pelvic exam on floor. And all I meant by that is because we had different, where I came from, we referred to at our medical center is that a floor meant that they stayed on their unit to have their exam done in the exam room, but it was not the floor as meaning the physical floor that you walk on. It just meant on their unit in their exam room. But at the facility I went to work at, that didn't mean that. That meant the floor you walked on. And so it brought a lot of chuckles and people had a good time at it. And it was a teaching experience for me because the insurance company and a few other people wanted to understand why an adolescent wanted to have a pelvic exam physical on the floor instead of on an exam table like a normal person would have. Okay, and make sure it accurately reflects the patient's condition, treatments, test responses towards those things, and any untoward incidences. So Mr. R's sister has suspected Mr. S sometimes forgets to eat. In which part of the nursing care plan would the nurse suspect to find this statement? Offer snacks and finger foods frequently. Assessment, diagnosis, planning and outcome identification, interventions, and evaluations. If you said D, interventions, you are correct. You teach Mr. R's sister about important precautions associated with new prescriptions. Afterwards, she accurately summarizes major self-management strategies associated with this drug. Which steps of the nursing process applies to her summation? Assessment, analysis, planning and outcome identification, intervention, evaluation. That's right, if you said E, evaluation.